Welcome, everyone. We're happy to see you here. This is the last, but definitely not the least in terms of importance of our heart cafes, series of heart cafes we held ACC, WCC. And thanks to AstraZeneca and their support, we will be talking about a very important subject, which is how to build stronger health systems after COVID and what has COVID taught us about it. Because if we are in the business of saving lives and ensuring healthy hearts everywhere, we cannot possibly do that without having healthy, strong and resilient health systems. As we all know and experienced firsthand, the pandemic had turned our world upside down and had brought the health systems of many countries on their knees, exposing a lot of shortages, shortcomings, and different fault lines. And what we have to do now, we have to learn from that and train the workforce differently, expand the capacity of the workforce, allow for certain tasks to be carried out by nurses or community workers, as there never will be enough specialists to treat those who need care. Countries need to take transformative actions to build stronger and more resilient health systems. And transformative action is a big buzzword nowadays, but we have to figure out maybe it will be helped by my esteemed panelists to understand exactly what does that mean and how does that translate in practice when we talk about in the context of ensuring better prevention and better treatment and care for cardiovascular health. So to help us answer some of these very, very big questions in the next 45 minutes to an hour, I am joined by Dr. Taskin Khan, who is the WHO's lead on cardiovascular disease, Professor Prabhakar Doraija, who is the director of the Center of Chronic Disease Control in India, who is also a WHF board member, and who is also the principal investigator of the COVID-19 CVD study. And Professor Eileen Hanberg, who also has a very, very long title after her name. Bear with me. She's a professor of medicine and director of the Cardiovascular Clinical Trials Program in the Division of Cardiovascular Medicine, and also a president of Preventive Cardiovascular Nurses Association. Welcome to the show. I will start with one question that I will ask to each of you before going into a more deeper discussion individually. And I would like to ask you to answer that question in a succinct way. And that first question is, if you can go back in time, what one action would you prioritize at the outbreak of the pandemic? And I will start with you, Eileen.
That the only thing that could be put out into the press is the truth.
Well,
Amen to that. Session over. Prabhakar?
right, going back in time and going back to December 2019 when we did not know anything much, I think the one action that I would do is protect the people by providing them advice with regard to isolating from people who have the illness.
Thank you. Taskin?
For me, it would have been to prioritize the legal and policy framework through which emergency preparedness, outbreak control could actually perform.
Interesting and quite varied replies. So that will be an interesting discussion. Okay, now we're going into a bit of a more of a deeper dive into building a stronger system and learning from COVID. I will start with you, Prabhakar. And my first question to you is, what are the implications for people living with CVD in a pandemic context?
So there are multiple implications for people with CVD. in the context of any pandemic, for example. So the COVID pandemic has taught us a lot, and in the initial phases there were lockdowns in multiple parts of the world, which actually decreased the access to cardiovascular disease, stopped screening for cardiovascular disease, impacted the rehabilitation for cardiovascular disease. And actually, when we looked at patients who reached the hospital after a heart attack, they were the severest patients, which meant that many people who had mild disease and would have benefited from the treatment did not reach the hospital. So it impacted, the pandemic impacted people living with cardiovascular disease in multiple ways, particularly the vulnerable who were unable to procure drugs, and that also would have left major impacts. And many of these have not been accounted for in what we have seen post-pandemic.
Thank you. You're also one of the principal investigators of our World Heart Federation's COVID study, which reminds me I did not introduce myself. I am a member of the World Heart Federation. My name is Buriana Pervan, and I'm the Director of Strategy and Communications. So we did a study, World Heart Federation did a study of linking COVID and CVD. And it will be interesting, I think, for the audience to learn a little bit more about what is unique about this study and what are the initial findings.
So the first thing is, when we began the study, we realized, we did a systematic review, and we realized most of the data on COVID-19 were coming from from North America, mainland Europe, UK, China, and Australia. That's the global north. There were hardly any, in fact 95% of the reports came from these countries. There are only 5% of the reports which came from low middle income countries, of which India had contributed to 2 or 3%, and the rest were, Africa had less than 1%. So that made us think that we really require to know what's happening in these countries, because you're eliminating a vast swathe of the population, almost 3 billion people, and we needed research from these countries. So we requested all our members from the member countries to participate in the study, which essentially was a very simple design in terms of collecting data on admitted patients with COVID, looking at their comorbidities and looking at cardiovascular diseases, and following them up for a month's period and looking at the mortality. In the end, we got 23 countries to participate with 40 centers, and we recruited 5,000 patients, 5,313 to be exact, over a 1-year period. What it showed was the South Asian ethnicity had the highest, the Asian ethnicity actually had the highest mortality, but when we did the adjusted analysis, we found that people from the low middle income countries and upper middle income countries, which was largely Mexico and others, had 3 times higher mortality as compared to other countries. So clearly there was some ethnic variation in terms of mortality, but on a deeper dive, you realize that it is because of the health system issues, which we will discuss subsequently.
And let's just continue with you for a little bit, because this study was then followed by a long COVID study.
Yes.
Looking at long COVID outcomes. Can you tell us very briefly what is the goal of this study and how might the results help inform health policy as we move forward?
So the long COVID study is still ongoing. What we plan to do is to recruit at least 2,000 patients and follow them up over a period of 1 year. We have so far, I think, recruited around 1,800. So it's going to complete. But in terms of follow-up, we still have some more time. We have done 3 months follow-up, we've done 6 months follow-up, and at 1 year follow-up, we just have 100 or 200 patients. So this will give a lot of information in terms of the long COVID study, long COVID features, because again, to emphasize the point, the long COVID studies again are available mainly from high income countries, and we do not have any data from Africa, India and other places, and we will have enormous amount of data maybe by the year end or early next year.
Thank you. My last question for you would be related to the rapid increase in the use of telemedicine, which is what happened during the pandemic. And if you can share with us your views about, do you think that this has had a major impact on the way we think about digital health as part of models of care, and what is the impact to access to care? Can it help bridge some of the gaps that you had identified?
So I think to use a very cliched statement, every challenge becomes an opportunity. Every problem gives us a solution. And I think the COVID-19 pandemic has suggested that telemedicine could be a potential solution in terms of reimagining the health system. Chronic care, particularly care of patients with cardiovascular disease, diabetes, cancer, and so on, does not require the patient to come to the clinic, come to the hospital after the first visit, and can come maybe 2 3 years later. So most of the time they're coming in for refill of medicines, just to chat with the healthcare provider. Therefore, a hybrid telemedicine program would be one of the solutions if we were to reimagine the health system in the future in terms of providing equitable care to population. What telemedicine would do is improve access to patients. But people might argue, where is the digital literacy? Where is the literacy for people to use telemedicine? That's why you require a brick and mortar center which provides in-person telemedicine assistance. You require assisted telemedicine, and in the subsequent visits, patient can actually connect. But also we could look at various models where we can go to the patient's home. There are systems where you can actually initiate telemedicine at the homes of the patient, telemedicine at common places where people meet, like railway stations, movie theaters. So there are multiple ways which you can use telemedicine. Many of the things that were initially thought which were considered difficult, we have overcome that, particularly interoperability of the various platforms that are likely to be used, or various devices that are being used in telemedicine. But many of those things have been cracked, and we will be able to generalize it at low cost across the world.
Thank you. It will be interesting to know from your perspective, Eileen, what has the pandemic and what has the aftermath taught us about health systems and access to care, and how might the different care models that Prabhakar was mentioning help address these problems in the future? What is your view on that?
I think that the pandemic provided a amazing science experiment in how to reimagine healthcare out of necessity, right? And so we had patients who, no one could go out, and so we were forced into a telemedicine environment. And I think that all, as you alluded to, was very positive. I think the reticence in it in the U.S. is about reimbursement. So because it forced that as the model of care, then insurance companies had to pay for it. And so then health systems were able to say, okay, we can adopt that model because we're going to get paid for it. Prior to that, if you made a call to a patient, there was no reimbursement for that, so nobody wanted to do that exercise. And so I think the pandemic pushed telemedicine in a way that it might have been, 5 or 10 years down the road. I think that telemedicine has amazing ability to allow access to care in a way that, certain pockets of the world have done for a long time. Out in the outback in Australia, they've had telemedicine for a very long time. This made it happen on a global scale and just down the street. If you can't come out of your house because you're quarantined, you can't get down to the big high-rise physician office just like you can't in the outback. And so I think that pushed that agenda forward. I think it doesn't take away, I don't think telemedicine's quite as sophisticated as most clinicians would feel comfortable with from a diagnostic standpoint. Simple things, yes, but complex cases, you want to see the patient, you want to touch them, you want to do the full exam. And so I think that will always be the case. But the chronic disease management that you talked about, I think is true. I think where we're going to get mired down is this whole issue of HIPAA and privacy and a platform that's totally secure. When we think about almost everyone around the world these days has a phone. And that is the framework for telemedicine. And so I think we have to get out of our own way a little bit to decide what's really more important. I mean, to think that they're not following you on your phone would be naive and unrealistic, because they can tell you what shoe you're going to order tomorrow based on what you ordered last week. And so it's more important to get people access to care. And so I think in underdeveloped countries, it's not that there aren't phones there. I mean, a lot of people in that's how they spend that money, and everyone has access. So I think we have to think out of the box to make it even more accessible.
Yeah. And we talked at the beginning about these transformative actions that countries need to implement. And you mentioned some of these. Are there any other actions that you see were absolutely necessary if we are to get there and to build stronger health systems?
I think that healthcare providers have to step up and be a stronger voice. We can't be managed by administrators and health authorities without the voice of the provider. And without that voice, and along with the patients, because we can anticipate what we think will be good for patients, but we need a patient voice in those decisions as well. And, you know, medicine has become big business, and it's being run by businessmen. And how many talks have been here at the meeting about venture capitalists buying practices? And so I think providers in the healthcare system need to step up and really take leadership roles. Professional societies need to step up and take really strong roles in helping guide how practice and how healthcare goes forward.
Just after spending 3 days here at ACC WCC, do you think there is somebody missing in the discussion? An important actor who we need if we want to get to a place of strong health system and healthier hearts?
I think patients obviously need a stronger voice, but I would also say that the nursing profession needs a stronger voice. I said this in an earlier session, there are 27 million nurses in the world. And if we are going to move any kind of effort forward on a global scale, we need to utilize boots on the ground manpower, whether it's healthcare community health workers, whether it's nurses, to help us get directly to the people who need that the most. And so we need to have that voice so we can figure out how to operationalize all these wonderful things that we want to do to improve cardiovascular health.
Absolutely. Thank you, Eileen. Taskin, over to you now. Access to health care and universal health coverage is, of course, a key issue for the World Health Organization. What impact did the pandemic have on access to cardiovascular care, and what are the short and longer term impacts of that from the global view of WHO?
Thank you, Boriana. In fact, I think the pandemic actually strengthened the cause for universal health coverage and the need for the elements of financial protection, service coverage, and population coverage. Those are the sort of 3 tenets of universal health coverage. But more importantly, what we saw particularly with service delivery and care, and I think Prabhakaran said this already, was that there was great disruption of services. In a parallel world, we saw disruption of working. Overnight companies that were physical and required you to go to work every day actually moved to a completely virtual form of working, and that came with its own little challenges. So the health system, which was already fragile in most settings, and which, if wasn't fragile, the pandemic certainly in the first couple of weeks exposed the fragilities, showed that people with long-term problems like cardiovascular diseases, the chronic diseases in particular, the first sort of services that were decided not to be necessary were things like screening for cancers and things, and it's about prioritization. And we do get that in an emergency setting, you do need to refocus. However, we can be better prepared and better organized for some of that. And that, I think, comes to the fact that the long-term effects of the service disruptions we saw with cardiovascular diseases, so service disruption for hypertension, for example, was about 53%. That's over half of the hypertensive population not getting access to their treatment. those kind of long-term effects we know already. That means more people getting heart attacks, more people getting strokes, more people requiring quite a lot of expensive care, and further decrease in financial protection and setbacks in universal health coverage. So there are the short-term effects which were very visible in the fact that patients were getting sicker. There's lots of data to show associations, but there's still more data needed. Also, as Prabhakaran said, I think in the beginning, Italy and China were really driving the data sets. But the truth is we don't know much about what happened in Africa, where most of the cardiovascular disease burden currently sits. So it's a very multifaceted, I think, response, but one that we can learn from and need to do better in terms of data collection and quality.
Yeah. And a follow-up question from that one would be the long COVID, a significant challenge for continuing to be a challenge for health systems around the world and also for individual health professionals. Do you think the long COVID will be the next health crisis?
Oh, not consulting my my magic ball here, but the thing is, I think in terms of long COVID, there's a lot that needs to be done for us to understand it better. I think there's a whole lot of definitions even circulating post-COVID, long COVID, long sickness in people with COVID. There's all sorts of different definitions. I know the WHO has a pretty inclusive definition now, and it's about as good as it's going to get for a while. But the truth is, it's a bit early to predict whether or how it's going to affect people. We already know that it's affecting millions globally, but the actual translation and how we see some of those causal associations, I think the study that the WHF is currently commissioning on long COVID will help to answer some of those questions.
And Taskin, I'll ask you the same question that I asked Eileen. Do you think that there is somebody missing on the table when we talk about building strong health systems?
So there's lots of players, I think. I think there's the need to convene multiple stakeholders, and I think you can't have the conversation without policymakers, without people who are actually responsible for making the decisions that translate into the ground. But as well, I think the allied health professionals are quite important. I think we all advocate for team-based care, but I'm not sure how it exactly translates, on the ground, and whether people understand what team-based care means and how roles and responsibilities should be identified. But certainly there's also those people that are responsible for decision-making that need to also be part of the conversation.
Yeah. And how can we best support health professionals in their response to COVID and in dealing with challenges of providing healthcare moving forward?
So I think this is pretty much the same. I think we really need to get better at defining roles and responsibilities and allocating tasks in the various systems in the various facilities within the health system, but also at the population level, and also in terms of regaining some patient education about what healthcare professionals should be doing or do actually, and who is responsible for what. I think that's very important. Organized care is really, really important in health system service delivery.
Yeah, thank you. Prabhakar, the same question to you about the missing person.
So as both of you were speaking, I was thinking of who are all the missing people. You mentioned the patients, nurses, allied health workers. You're there from the media. I was going to say media, but you're there from the media. So I think the one big group of people are missing are people who can make decisions, the policy makers, the politician. So I think you require a politician in this argument.
Okay, which leads me to my final question. for all of you, and I would like to ask you to answer in no longer than 1 minute. So it's a proper pitch, and it goes like this: if you had 1 minute with a top decision maker in your country, what would you tell them to convince them to invest in cardiovascular prevention and care? I'll start with you, Prabhak.
Oh, okay. Right. So if I were to talk to the Indian Prime Minister, I would say, sir, you have seen so many young people dying of heart attacks very recently, but you also know the economic losses. You are a great proponent that India should become a developed country by 2047, but and towards that, you are trying to get a $5 trillion economy for India by 2025. The Harvard study has estimated that India will be losing $2.17 trillion by 2030. So clearly, there is a huge need for us to invest in cardiovascular disease prevention, universal health coverage, financial protection of people, and we urgently need a program. Thank you, sir.
Thank you. Eileen, your view?
Oh gosh. I don't really know the answer to the question. You know, in the context of what we're talking about, if I had one thing, I would say that if there was some way to improve our societal understanding and acceptance of vaccination, to try, because if you think about risk reduction with flu vaccine for cardiovascular disease patient, that one shot can be as effective as a year of blood pressure control. And if we're in this space of pandemics and communicable diseases like COVID-19, this understanding of vaccination needs to come back to the science and not the politics. And somehow to change that conversation back to what's for the good of humanity and where's the science behind that, and take all the rhetoric out and somehow make that a focus.
And to add to your opening answer, which was tell the truth.
Tell the truth. Yeah.
These two go very well together. Thank you. Taskin.
So I feel like I have a little bit of an unfair advantage with this one because it's kind of my job to make the case for cardiovascular diseases with ministries. But for me, I think the argument is simple. Cardiovascular diseases are killing more of your population than any other disease. We got into health with the premise of saving lives. It's quite simple. A quarter of the adult population, for example, is hypertensive. How are you going to save the most lives? Invest in cardiovascular disease prevention and control.
Thank you. Do we have some questions from the audience? Yes.
DJ Lackready from the Kansas City Heart Rhythm Institute. As a tertiary care cardiologist, as an electrophysiologist, you see a very skewed group of population that's post-COVID presenting to you with cardiac arrhythmias, myocarditis, elements of left ventricular dysfunction, so on and so forth, which really created a dramatic awareness towards the post-COVID cardiovascular impact. When you really take a step back from an epidemiological standpoint and a population health standpoint, how do you think we should design our reaction to this public perception of this a tsunami of post-COVID cardiovascular tsunami that's coming our way, and really calm the nerves of these people, because all these things existed even before, and perhaps COVID really provided that beautiful disease model that we did not understand before, right? The impact of post-viral immune-mediated mechanistic impacts on cardiovascular autonomics and myocardium and everything else. So your take on it, and what should be the message, and how should the cardiologists conduct themselves rather than infuse more panic in general public?
Who would like to take this on? Eileen?
I think it's interesting what you say because, you know, we're a this moment now kind of society. And so, you know, COVID was the big thing and people have moved on to other things. And there are people living with long COVID who have these sequelae of the disease. And I think the best thing that we can do is provide compassion and be willing to listen and understand. I already hear patients who come to my clinic and say, I've had these complaints and nobody believes me. And so I think it's more around compassion about something we don't understand well, and we have a lot to learn. And it's not been that long since we just opened up a world. And so there's a lot to do, and we don't understand it. And I think the unfortunate thing is patients come to us as providers and want us to have all the answers right away. And there's a lot we didn't understand about COVID when it started, which created a lot of the misinformation. And as we learn things, you know, we've shifted our understanding. I mean, clearly what we thought about thromboembolism very early on shifted over time. And so I think just compassion to be willing to take care of those patients and help them through the process and understand the sequelae and how best to treat it.
Thank you, Eileen. And if I may add from a public perception communications point of view, be transparent and don't be afraid to show yourself as vulnerable and unknowing at the time. But you know, speak the truth. So there is no more or less room for confusion.
No,
Prabhakar.
I just wanted to give a medical answer to that question because what happens in tertiary care may not be true in terms of the community. It's very early days for us to evaluate the long-term cardiovascular complications. One thing we clearly understand that there is increased thrombogenicity, so increased pulmonary embolism and increased myocardial infarction in the early phases. But once you go beyond that phase, I think from the whatever limited data that we have, it doesn't affect the heart. Long-term affection of the heart has been related to drugs and several other things that happen in the acute phase. So we will have to, the jury is still out and we'll have to wait for that answer. But till that time, the problem is we are actually communicating some kind of misinformation. Many people think it's the vaccines which are increasing the heart attacks. So we have to clearly convey that message. Vaccines are far more protective. There is a minuscule increase in complications, but the benefit to risk ratio is huge. The benefits are huge, and therefore everybody should get vaccinated.
Thank you. Taskin, do you want to add?
No, I think you covered it very well, Prabhakar. And the truth is we don't know, and we need to be transparent about it and also wait to see what happens.
Any other questions?
Yes.
Yeah, go ahead.
Hi, thank you. My name is Mark. I'm from Transplant Cardiology here in Florida. So, question to you, sir. In perspective of India and other Asian countries that you're aware of, can you comment on any particular large-scale, say, government-sponsored kind of zero-cost to patients initiatives for telehealth that has actually worked, specifically in reference to cardiology? It might just be cardiovascular investigations or actual consultation or intervention.
Right. So there's no state government program, but there's a central program called e-Sanjeevani for promoting telehealth. But this is still a basic system, which is an EHR program. It actually collects data, and the consultation has to be initiated by the patient if required. There's no electronic decision support system in that. So there are several pilots that are going on in terms of evaluating whether adding an electronic decision support system, adding a point of care device at the assisted telemedicine center, adding AI-enabled ECG or several other parameters will be of help. So reports will come out, it will take 2 years, but to answer your specific question, there is no state government supported program, but many people are considering, many governments are considering doing that, but there's a strong pitch from the central government in terms of this program called e-Sanjeevani.
Are you aware of similar programs across the world in the
I'm not aware, sorry.
Before I close, just I want a confirmation from the audience and from the esteemed panelists if you feel that we know what these transformative actions are, and we kind of know how to implement them, or not yet. 50%?
Sorry, I didn't get the question.
Transformative action that we need to ensure stronger health systems. After 45 minutes of talking about it, do we have the feeling that we know what these are, or at least some of them are? And then the follow-up question is, do we know how to implement those?
Yeah, I'll try and answer both the questions. The answer is that yes, the health system needs huge transformation. We need to reimagine the health system so that the cost of the healthcare comes down. A large majority of the healthcare costs is what we call as the last 6 months of care. And so how do we reduce that care? How do you prevent? Because prevention is not given adequate importance. How do we invest in prevention? These are two questions. The one big missing piece is the patient voice. We don't talk to patients. We don't talk to the consumers. When there's marketing, for example, for a product, people go and talk to people and see how the product can be sold. And we have never done that. So there are some things which we can learn from industry. We can learn, they do what is called as discrete choice experiments. They do people's voice, photo voice. There are several mechanisms by which you can actually evaluate the health system by talking to the community and the patients. So if we have to redesign the health system, you need to talk to the community and you need to talk to the patients. You need to decentralize the care. You need to think of innovations. We're talking about privacy. Bitcoins are bad word, but they have good lessons for the blockchain technology can be a good technology for privacy where the patient becomes the owner. So you need to innovate and think.
Thank you. Taskin?
Yes. So, surprisingly, some things didn't change post COVID. The largest cause of death and disability pre 2019 was cardiovascular diseases. Today we sit here and that remains the same. The biggest problem with health systems was financial protection and the inability to provide quality services to all those who needed access. That also remains the same. I think the biggest thing that COVID showed was that the gap between high income and low income countries is not as great as we all envisaged. That even countries with historically strong health systems, when faced with magnitudes of problems, when faced with large populations of people getting ill, which we always saw with chronic diseases, was not able to sustain in the acute phase. Those things, I think, were sort of unique. And the misinformation and communication styles was the other big thing that I think COVID exposed.
Yeah, absolutely. Thank you.
I would also say that what has not transformed is the protection and support of the healthcare community in terms of providers. The quiet quitting is going on massively, and we don't have enough staff. And the COVID exposed that in a major way. The way everybody was taken off guard, but the way some healthcare institutions provided support or lack of support for staff, brought some very glaring issues. And I'm not I think we got through it and everybody patched it all together, but I don't sense that there's this real willingness to kind of re-examine the healthcare environment. Everybody just says everybody's quitting and everybody's retiring, and what are we going to do when we don't have enough staff? And so there are some real issues, I think, that need to be exposed at the health system level about staff and the burden that they're under. I think that COVID was unique, and that because things, at least in the US, became so politicized, that healthcare workers got a unfair brunt of very negative public opinion, and that ran people off who said, why? I don't have to listen to this anymore. I'm retirement age. Why would I stay around and get spit on, yelled at, screamed at? And so I think there's a lot of work to be done in this area for sure.
Thank you. One last question, Selena.
Hi, Selena Gore with Women Heart here in DC, in the US, but in DC. A few of you mentioned a few things. One, Prabhakaran, you mentioned we need to hear from the patients. So I'm a patient advocate, and our organization is a patient advocacy organization. And somebody else mentioned how patients are not being believed. Their symptoms are not being believed. Well, that's an experience of women writ large all around the world, specifically about cardiovascular disease. That is true. That has been true pre-pandemic. And my question to the panel is, how has the experience, the difference in experience between the genders, borne themselves out in the context of cardiovascular disease and COVID? And is that analysis being done in the context of the research that is being done now, looking at long COVID in particular?
Thank you, Selena. Prabhakar, you want to ask?
Right. I think, cardiovascular disease and women goes a long way back. For the last 50 years, we have been talking. And definitely, there has been misdiagnosis many times in emergency care because of the way women present, and also the belief that women do not get cardiovascular disease, which is completely wrong. And cardiovascular disease is the leading cause of death even amongst women. The only difference is, instead of presenting with a classic chest pain, they might present with breathlessness or back pain or vomiting or something like that. So that's one issue. Second issue is the inherent, is the time at which they reach the hospital for any illness. There is a considerable delay from the time of onset of symptoms, and those are societal issues which we need to consider. The third issue is at the level of the health system. What are the outcomes? And so there is some evidence now that once they reach the hospital, the outcomes are not really different. The pure study has shown that the outcomes are not different. There may be delays in care, maybe it's the resilience of women. So we really need to do better in terms of early identification and providing the treatment for women. And once we give the right treatment, the outcomes are definitely equal to men or even better. Because earlier it used to be thought women have smaller coronary arteries and surgery is bad for them and the mortality is higher, but that's no longer true. It's just to catch them at the right time and diagnose it and give the treatment. In terms of what happened in the health systems for COVID, I think we need to do that analysis, and that will be a good systematic review to do from the multiple papers that have been published, including ours, where we'll have the data.
Thank you. I think that's it, unfortunately. Sorry, go ahead.
One quick question.
Yes.
Heard about a lot of the challenges. In your view, what did you notice from either countries or bodies who really responded well? We heard bits and pieces of successes, however you want to define that. Early response, information control. What were some success models that we can learn from in these last few years?
So I can't answer for multiple countries. I mean, there are examples. New Zealand, for example, had great success. But I come from India, and I can tell what happened in India. We did a great job. At least initially, we did a great job. And I can tell you, in terms of the RT-PCR tests, which when it began, there are only 5 labs in India which were doing RT-PCR. And getting those tests done was a humongous job. You have to send the samples hundreds of miles away to get it done. Within a matter of 6 weeks, from 5, it went up to 1,000. From initial cost of around $80 per test, it came down to $5 per test. So that's a great success. The messaging by the politicians, including the Prime Minister, was accurate, so people stayed indoors. But where we failed, because while we accept that the successes, where we failed was in anticipating the second wave. And we because we were quite successful in the first wave, so we became little negligent not negligent, I would say, little lethargic in the second wave. Yeah, and that caused problems. But then they responded very rapidly. Vaccination coverage has been huge. In fact, if you look at people having taken at least 2 vaccines in the country, it's more than 80%. I don't think any other country has that kind of vaccination coverage. And that's a great success. So despite the great successes, there are problems, and we need to identify the problems and address them.
I think we have a lot of time to talk about problems in our daily lives. as people who are passionate for heart care and many, many meetings to come. Thank you, the esteemed panelists, for the energy and time at the end of a long Congress. I invite you to give them a round of applause. Thank you to the audience for taking the time. I know it's getting late and we're getting all tired, but I think that was a very, very rich discussion and one to continue.